Paul Salkovskis se licenció en Psicología, es psicólogo. En 1977, en la Universidad de Reading. También ha hecho un máster en Psicología Clínica y se doctoró en Psicología en 1990. Como digo, ha desarrollado una amplísima actividad académica que aquí simplemente está brevemente resumida. Él empieza trabajando como psicólogo clínico investigador, posteriormente pasa a ser investigador asociado y finalmente en el 99, después de casi 14 años trabajando en la Universidad de Oxford, ya llega a ser catedrático. También ha desarrollado durante 10 años actividad de profesor de Psicología Clínica y Ciencias Aplicadas y director de estudios de posgrado en la Universidad de King's College. Es una de las universidades más prestigiosas de Reino Unido. Del 2010 al 2018 es profesor de Psicología Clínica y Ciencias Aplicadas y director de los programas de doctorado en Psicología Clínica en la Universidad de Bath. Y en la actualidad es director de formación en Psicología Clínica, director de los programas de doctorado y director del Centro de Terapia Cognitiva de la Universidad de Oxford. Pero si a mí hay una cosa que me ha destacado cuando veía su currículum, es que él siempre ha intentado estar muy vinculado a la práctica clínica. De hecho, él empezó como psicólogo clínico y se especializó en terapia de conducta y psicología clínica. Además, ha estado muy vinculado a la práctica clínica a través de la Dirección de Centros para los Trastornos de la Ansiedad y el Trauma y el Centro para la Atención Especializada de la Ansiedad y Problemas Relacionados del Instituto Británico de Salud. Además, como figura reconocida a nivel internacional, ha sido consultor del Programa de Mejora de Acceso a las Terapias Psicológicas y miembro del panel de expertos para las directivas para la ansiedad de Reino Unido. Como digo, simplemente puedo hacer una pequeña aproximación. Él ha sido miembro y anterior presidente de la Asociación Internacional de Terapia Cognitiva y es presidente de la Asociación Británica de Terapia Cognitiva Conductual. Pero tiene otras pertenencias a muchas asociaciones científicas, de investigación, que simplemente por espacio pues no puedo reseñar. Igualmente atesora multitud de premios. Quizás de los más interesantes, de lo que yo ya he podido leer, está el premio Aaron Beck por la excepcional contribución a la terapia cognitiva, el Premio Internacional de la Academia de Terapia Cognitiva de 2010 y fue nombrado entre los 50 mejores investigadores del mundo en su campo. Durante toda esta actividad académica, investigadora y vinculada con la clínica, él se ha centrado en una serie de áreas de investigación, como son el trastorno de pánico y agorafobia, el trastorno obsesivo-compulsivo. Dani, no avanza. Vale, la hipocondría, pues, el dolor crónico, si le puedes dar tú un poquito, la ansiedad ante exámenes médicos y la toma de decisiones sobre la salud. Pero bueno, a nosotros lo que nos interesa sobre todo es la investigación y el trabajo clínico que ha hecho sobre el trastorno obsesivo-compulsivo. De hecho, Paul Salkovskis es un pionero en desarrollar un modelo cognitivo para explicar los procesos que hay implicados en el TOC, pero claro, tenemos que entender que este modelo cognitivo ha tenido una gran importancia en la práctica clínica. Es decir, mucho de lo que los psicólogos clínicos hacen con nosotros, trabajan con nosotros, vienen de estos modelos que se han desarrollado, que quizás no se conoce a la persona que lo ha desarrollado, pero está ahí detrás y tiene una importancia fundamental. Así que, resumiendo, nos encontramos ante un referente mundial en el campo de la investigación y el tratamiento cognitivo-conductual, en especial, aunque de otros muchos problemas, en especial de trastorno obsesivo-compulsivo. Y para mí, de las cosas más importantes, ha tratado siempre de unir investigación y práctica clínica. Es decir, no se ha dedicado a investigar y olvidándose de cómo eso se podía aplicar, sino que él siempre ha estado muy vinculado a la formación de psicólogos, a los estudios de posgrado, a dirección de centros de ansiedad. Es decir, él ha sido consciente de la importancia que tiene vincular la investigación a la práctica clínica. Pero es que además Paul Salkovskis es mucho más que todo eso. Nos encontramos ante una persona comprometida, solidaria. Comprometida y solidaria. que ha trabajado con diferentes asociaciones británicas, como Sin Pánico, Ansiedad Reino Unido, Toc Reino Unido, Toc Acción y Victoria sobre la fobia. Tanto es así que hace unos años unió sus grandes pasiones, la bicicleta y la colaboración con estas asociaciones, y recorrió 1.770 kilómetros en bicicleta en 14 días para recaudar 8.000 euros para la asociación Toc Reino Unido. Y 2 años después, se ve que no le había parecido suficiente, hizo el camino inverso. Esta aventura yo creo que solo es comparable a la de recorrer en avión más de 1.700 kilómetros, desde Londres a Málaga, más 133 kilómetros en coche hasta Granada, para colaborar de forma desinteresada con nuestra asociación. Durante toda su carrera ha escrito y participado en 218 artículos, 73 capítulos de libros y 9 libros, de los que 2 están dedicados al TOC. Así que me permito citar 2 de sus frases para terminar su presentación. La primera es que cuanto más veces hayas experimentado la realidad de lo que sucede, más evidencia habrás almacenado para responder a las dudas y pensamientos intrusivos que el TOC pueda dispararte. Y la segunda, el hecho es que el TOC tiene un costo inmenso para ti y tu familia. Y es una opción muy insegura. La buena noticia es que puedes decidir hacer las cosas de manera diferente y recuperar tu vida. Así que con esta esperanza y agradeciéndole profundamente que esté con nosotros hoy, que haya hecho el esfuerzo de venir, le dejamos con Paul Salkovskis.
Hola. My only Spanish. My apologies, but mainly my thanks for the warm welcome, for an amazing introduction. I'd love to meet this guy. He sounds great. This, in my view, this is the most frightening audience to speak to, because I know that mainly this audience is people who suffer from OCD and their families. You are the real experts. You are the people who know most about this problem. And that makes me anxious, because I'm going to tell you things that you already know. So I decided, with the agreement of my very kind hosts, to split my talk into 2. The first part is something I believe very strongly in, which is the idea of the patient and their families as an important part of the expert team. The expert team wants to treat OCD, to help people get better. And that expert team should be led by the patient and their family, not by the psychologist or psychiatrist. I'm not the team leader when I work with patients. I'm the team coach, and that's a good way to think about it. So the first part of my presentation is about how to get the best from your treatment. And this is directed to people who suffer from OCD and their families, but it's also directed to therapists and to the clinical team, because they should be paying attention to how to help the real experts to bring their problems to a conclusion. So, what I'm going to talk about is, what is OCD? Spoiler, we don't know what OCD is. But anyway, I'll talk a little bit about what we know. What is CBT? Cognitive behavior therapy. It is the best treatment in town, but what is it? How does it work? How do you find a good therapist? Well, you come to Granada, don't you? You come to Granada and you find a good therapist here. But even then, how do you find a good therapist? How do you get the best from therapy? Because if you're a patient and a family member, this is a huge investment, and how do you get the best from that? I'm going to talk about agenda. I'm a cognitive behavior therapist. I always set agendas collaboratively, together with the patient. So what should the agenda be? So let me also say something about the problem of cognitive bias. You know what cognitive bias is. Therapists have a cognitive bias. When their client improves, they go, it's understandable because they're doing good therapy and so on. So that's okay. We can be proud as a therapist. When things are not improving, and clearly that's the patient's fault or their family's fault or something like that. That's a cognitive bias because therapists protect their self-esteem. Unfortunately, patients also have a cognitive bias, which when things go well, they think it's their therapist who did it. And when things go badly, they blame themselves. We have to fight this cognitive bias. Because when things go wrong, it's the therapist's fault. It's not the patient's fault. It's not the family member's fault. It's because somehow the therapist has missed the point. I'm not saying it's easy. I'm not saying really that it's the blame of the therapist, but it's the responsibility of the therapist. And responsibility is a very important word in OCD. Because responsibility sits at the heart of what people with OCD experience. They think they are responsible for preventing harm. And if things go wrong, they will take that responsibility themselves. Therapists have to change the way they deal with that. So, what is OCD? Well, there's the diagnosis, which is that people with OCD experience intrusive thoughts, images, and impulses, both obsessions and compulsions. They're always both there, even if you don't see them. The compulsions are meaningfully related to their fears. So, the compulsions are really meaningfully related to their obsessions. And this is very important because obsessions and compulsions are not meaningless. Meaning is at the heart of what happens with OCD. By definition, the person tries to get rid of their obsessions. They try not to think of them, which we know is counterproductive, but it's very hard to stop that. More about that in a minute. But all of these things, the first four things there, they're not unique to people with OCD. Everybody has these things. OCD is defined by it interfering with your life. It's stopping you doing things you want to do. That's what defines OCD, not that people have unpleasant thoughts, images, and impulses, because everybody has unpleasant thoughts, images, and impulses. It's the interference with life. So, we don't get rid of obsessional thoughts because everybody has them. We get rid of the distress and disability. That's the aim. But that's the diagnosis. What is it really? Well, an obsession is a recurrent thought, image, impulse, or doubt, which tells the person that something bad might happen, and it'll be their fault if it does, the responsibility issue. And a compulsion simply follows from that. It's an action or a reaction which is intended to stop the danger, but also to get rid of the responsibility. And that's what OCD is. The disorder is that these two things together result in intense distress. I sometimes give a workshop with a person who suffered from OCD for 25 years and doesn't anymore. And we call that workshop Escaping from Hell. OCD is hell. It's hell for sufferers. It's often hell for families too. And that's what you need to escape from. Okay, so how do you sort the therapy out? Well, there are lots of therapies on offer. There's CBT, there's psychoanalysis, there's flower fairy therapy, there's stupid therapies, aromatherapy, there's mindfulness. Okay, so what you should do is follow the evidence. I've done some work on medical decision-making, and My preferred type of decision-making is something called evidence-based patient choice, which is that the clinician shares with the patient what the evidence is, so they can choose what it is. And yeah, would you choose a therapy that has evidence that it's effective or one where there's no evidence? Well, you can find out what's effective. Use the NICE guidelines. They're British, but they're also independent. They're not funded by drug companies or computer companies or book companies. They're funded by the health service. And it says, quite simply, CBT, CBT, CBT. Medication, second line, and a helpful adjunct in some instances, not simultaneously. That's easy. CBT, here's the problem. You see, what is CBT? Because I know patients who've been told, oh, I'm going to give you CBT, get on the couch and tell me about your childhood. Yes, that's CBT. So it's not necessarily what the therapist calls it, is what it really is. And it should be mostly focusing on the present. So that's a sign. It mostly focuses specifically on the problem you bring. It helps you define what the problem is. It mostly focuses on you as the patient. It's an active treatment, and it's very hard work because it's a doing treatment. It's a talking treatment, but mainly a doing treatment. And it's well-researched, it's highly tested, and it's constantly evolving. It hasn't properly evolved there because the word isn't finished, but it's evolving. SSRI medication is an alternative, but not in combination as a first-line treatment. You shouldn't be doing two things at once. The most recent data, I'm not going to talk a lot about this, is that antipsychotic medication is mostly going to make you fat and sleepy. It's not going to help your OCD. It's not a first-line treatment for OCD. There are severe doubts about its effectiveness, but getting fat and sleepy is not a good consequence. And at present, right now, this may change, other than CBT, there are no other psychological treatments. Psychodynamic treatment generally probably makes things worse. There's just nothing else there. Now, that's a shame, because it'd be nice to have other treatments. Other things don't do harm. I mean, doing exercise is a great thing. It doesn't treat OCD, but it's good. I think it was mentioned, I cycled from one end of England to the other with several OCD sufferers, and we had a great time. It didn't cure their OCD, but we all got fitter. Okay, so, more understanding. Well, unacceptable intrusions, thoughts, images, impulses, everybody gets them. When someone has OCD or is vulnerable to OCD, though, they think these intrusions mean a bad thing will happen and they'll be responsible. And how they respond is try too hard. OCD is a problem of trying too hard. OCD patients are not lazy. They work much too hard to be certain that they're clean, to be certain that their thoughts are pure, to be certain that the door is closed, and so on. And what happens is the solution becomes the problem. Oh, too far. Too far. No, I want to go backwards. Backwards. That's it. Okay. The solution becomes the problem. People with OCD, if you have a contamination fear, contamination's not your problem, it's the washing that's the problem. If you have a checking fear, if you check, it's the checking, it's not the door, it's the checking. It's not the fire, it's the checking. The solution is the problem. The things that people do, feel compelled to do, is what actually creates the problem. Okay, so, if you suffer from OCD or any other anxiety problem, how does it work? Well, it's very simple. We know for sure that people suffer from anxiety, obsession being one example of anxiety, because they think situations are more dangerous than they really are. That is the basis for pathological anxiety. What you do in treatment is you help the person to consider an alternative, less threatening explanation. So, someone has OCD and they come into my office and they say, "Doctor, my problem is that I'm contaminated," or "My problem is that I'm a child molester." And when they come into your office, as a clinician, then they're saying their problem is something like that. What you're going to say in therapy, after a little while, is, maybe your problem is not that you're dirty, maybe your problem is you're a clean person who's afraid of being dirty. Because, and this is very important, because if your problem is that you're dirty, you should wash. Simple. If your problem is that you're a child molester, you should keep away from children. But if your problem is that you're afraid of being dirty, well, you need to confront the fear. You don't need to wash, you need to stop washing. It's very hard. It's very hard. Almost impossible at the beginning, but that's what it is. And you need to, it's about thinking differently about what's going on. And an alternative explanation, which is what you need, in CBT, it's the thing we call the formulation, which is worked out during therapy between you and the therapist. A formulation, if it's to be helpful, it has to fit with two things. First, it has to make sense. It has to fit with the person's past experience. And secondly, it has to work when they test it out. In other words, it has to survive their future experience. So it's not, "Oh, trust me, I'm a white-haired professor with a grey beard." No, don't do that. "Trust me, I'm a doctor." No. What I would say is, don't trust me, work with me. Let's work together, because good therapy, in my view, is a really simple thing. It's about two people, sometimes more, family members, but let's say two people, patient and therapist, patient and therapist, working together to find out how the world really works. That is what you're doing in therapy, to find the truth. Because if the truth is that you're dirty, you should wash. If it is that you're afraid of being dirty, you should tackle the fear. So, here's the point. Here's maybe the point. Oh, I did too many. Okay, no. Okay. There are, in therapy, two experts in the room. So, if you come to see me, I know a little bit about OCD and anxiety and its therapy, and so I'm an expert in that. But if it's you I'm seeing, I know your name, I know your age, and I know that you've had the problem for 5 years. That's all I know. I have no expertise in my patient. But if you know about you, you're the expert in you. And this is what I mean about the patient as expert. The patient, only the patient and their family know about them. And it's putting these two expertise together. That's what therapy is about. And it's a fantastic thing. And it's about empowering patients, helping patients to see that actually that what they think and what they do is important. So, let's think a little bit about OCD. Where does it come from? Truth, we have no idea what causes OCD. We have no idea. We don't know. It's clearly not a genetic problem. It's clearly not a diseased brain, as far as we can find out. It's not the fault of families. We know that for sure. So it's a complicated mixture of things. So OCD is something I'd call a final common pathway. It is a very complicated mix. And one of the main causes of OCD is bad luck. Really, bad luck. At school, you were bullied. You know, somebody didn't like the color or the way you talked, and they bullied you, and then the bullying then snowballed and your self-esteem was damaged. For example, or you know, one day something terrible happens and you think it's your fault. Bad luck, bad luck. I'm not going to talk a lot about that, but it looks to me like OCD is the perfect storm. It's when things come together and people understandably make choices, for example, to use rituals to control their anxiety. But rituals don't control anxiety, they make it worse. But people get trapped in a cycle. And then there's the problem of labeling, because we should not pretend, I had a conversation last night about this, we should not pretend that we know what causes OCD. We've done research, other people have done research, which says that you should be very careful, because if you tell people that OCD is caused, for example, by a brain disease, it makes people more pessimistic. It makes them feel hopeless. If I have a hole in my head, what do I fill it with? You can't go to the do-it-yourself store and find something to fill it with. There is no evidence of a hole in the head. There's no evidence of a biochemical disturbance. There's no evidence for any specific cause of OCD. So do not give people something which will make them despair. Okay, what is CBT? CBT is, in fact, you see, I'm a fraud. I say I'm a therapist. I say I do CBT. I do not do CBT. My patients do CBT. CBT is self-help, because if you come into my office and you say, help me, doctor, give me CBT, do you know what? I can't. Only you can give yourself CBT. I can help you. I'm the coach. I'm not the team. I'm not the footballer. I'm the coach. So actually, CBT is self-help. But self-help is, by definition, if OCD, self-help is not working. So you have to go to therapy expecting to be helped to understand what's going on, to help to understand what the problem might be, and being helped to choose to change. In my view, the most important element in CBT is people choosing to change. You should go to therapy expecting a therapist is going to need a lot. The therapist is not going to do it. They're going to need you to help them. You're going to have to explain it to them. You're going to have to then do stuff. The therapist isn't going to do anything. If you decide to take part in therapy, well, please take part in it. Be 50% of the team, or 30% if your family's involved too. Make sure you have the right therapist. If you look into your therapist's eyes and hopelessness looks back at you, that's very bad. Because it's really hard to work with a therapist who feels hopeless. And some therapists, I'm afraid, feel hopeless. How do you assess your therapist? So a lot of therapists think, how do they assess their patients? But you have to think about how you assess your therapist. If they're acceptable, if you think that in your assessment that the therapist is a good therapist who could be trusted, who you can maybe rely on, then try to make the most of your time. Work actively with them. What I mean by acceptable is mutual trust, mutual respect. Because I see, in my work as a therapist, I see miracles happen. I don't make the miracles happen. I think the patient makes the miracles happen. A patient who has been worried about contamination for 20 years puts their hand into a lavatory, licks their fingers. It's a miracle. And this is part of the journey towards getting better. But they only do that because they think that I understand. They think that you, if you're the therapist, understand, and that you can be relied on. Because the things that we ask patients as therapists, the thing we ask patients to do involves something we all understand as a leap of faith. It's a leap of faith. It's something, we ask people to do impossible things, and they do them. And I, as a therapist, am permanently grateful for the wonderful things that my patients allow me to share with them. How do you get the most from your therapist? Well, make sure you got the right therapist. Make sure that they're offering you the best available therapy. If they're offering you psychoanalysis, sack them. Make sure that you then understand what the therapist is trying to do. They're difficult to understand, these therapists. They're very unclear sometimes. You think you know what they're trying to do, but maybe you have to ask. exactly are you trying to do? And what are we doing here? What's the point of this? Try to help motivate them. A lot of therapists talk about poor motivation in patients. I have never met a patient who was poorly motivated. Patients are always desperate to get better, but they find it very difficult. I have met therapists who are poorly motivated. How do you motivate the therapist? Well, we'll talk about that. Make sure that your therapist keeps on track. I mean, make sure that they're focusing on what's important to you. They do the right work, and you set you the right homework. I mean, homework is really important. You have to make sure your therapist sets your homework. And if they forget to ask you for the homework in the next session, because that happens, remind them. You shouldn't have to, but you might help. Sometimes you might want to help them involve others. You might suggest to your therapist that maybe that your husband, your wife, your mother, your father, your children, that they maybe should be involved too, and that's important because therapists forget. Okay, I'm not going to talk about this. There are many different types of therapists, clinical psychologists, psychiatrists, occupational therapists. Your therapist should be somebody that you can trust or believe you could come to trust. They could be someone who can respect you and you can respect them. Someone who's good at therapy and helping people to make changes, you want to know that. Somebody who knows how to avoid the most serious problems in the treatment of OCD. And that's difficult. They really need to be a bit of an expert. And someone who keeps up to date. If your therapist is not keeping up to date with new developments in OCD, they're not a good therapist, I'm sorry. You really should be up to date. When you're choosing a therapist, think, well, where are they? Granada, that's good. Oh, I like Granada. But if you're coming from Valencia, then maybe that's a problem. It's too far away. What training do they have? You should ask them, hey, what training do you have? Do you have any specialist training? And it's difficult. I know it's difficult to ask therapists this, but you would ask your plumber. You would ask the electrician, If the electrician says, well, I did a half-day workshop on how to be an electrician, that's like saying I did a half-day workshop once on how to treat OCD. It's not good. You don't want that person treating your OCD or doing electrical work. Sometimes gender matters. Sometimes it's more difficult to talk to a man or a woman, and sometimes you have to ask in that way. What's their preferred way of working? Do they work intensively or do they work in a spaced way? It'd be helpful to know how they intend to help you in that way. Do they think that OCD is something that can be cured or not? And if they don't think that OCD is something that's cured, find another therapist because it's not helpful. If they're pessimistic therapists, bad idea. Do they set homework? Do they actually go with you to where the problem is? And if they do, good. If they don't, difficult. Danger signs. Here's the danger signs. You ask your therapist some questions, and they don't want to answer those questions. That's a danger sign. You really don't want a therapist who avoids answering your questions. You're part of the team, and if your team coach won't tell you anything, you leave, get another team. Somebody who's an expert in everything. I see therapists advertising themselves, and they're experts in OCD and panic and treatment of cancer and better golf and everything. List 30,000 things. No, nobody's that good. The pessimistic therapist, avoid the pessimistic therapist. If your therapist does not believe that you can be helped, you don't want to work with them. Ask them what qualifications. Oh, by the way, I didn't say, you can have these slides. I know they're in English, my apologies for that, but you can have the slide. If anybody wants, the organizers will give you the slides, so don't worry about that. Don't be impressed by titles. We had this lovely introduction, and I was embarrassed how amazing the introduction was. Don't be impressed by that. Be impressed only by the man or woman who relates to you as a person. That's what matters, not titles, not professor, doctor, nothing. Those are trivial things. It's possible to be a professor and be a terrible human being. Trust me, I'm not saying I am, I'm saying I know people who are. Make sure that they have supervision, because I get supervision still. I've been around for a long time, and I've done a lot of therapy, but I still have supervision. And you want that. You want somebody else to be looking over your therapist's shoulder and helping them understand things better. So ask them, do they have supervision? Don't worry about junior therapists. They're very good. Junior therapists are very up-to-date. Their training was last year, not my training in OC, my first training, 40 years ago. I've done a little more training since, so don't worry too much. But trainees are more likely to be up-to-date. They're more likely to be enthusiastic, and you want an enthusiastic therapist who looks at you and says, do you know what? We can work on this together. That's what you want. They're also less likely to be, the English term is up themselves, arrogant. They're less likely to think they know everything, and that's fine, because they don't. Nobody does. Okay, so the agenda, good CBT therapist will appreciate working with an active service user, an active patient, and if they don't like you being active, you need a different therapist. Suggest that as a service user, you request some agreement on what you're going to do in therapy, right from the beginning, and here's what it should be. You want the therapist to spend some time understanding you as a person, to hear your story. Because OCD does not appear in a vacuum. There's a story, and the story is partly about who you are and what your values are and what matters to you. You want some discussion of how best to deal with questions, including things like reassurance. You need to think about that. And you need to agree on what the target problems are. You need to be working on the same thing. And it may seem obvious, but it isn't always. You should have a general assessment leading to a specific assessment. So the therapist should be asking you about things in general and then going very specific, leading to a formulation. The thing we call a shared understanding. I'm going too fast. My apologies. A shared understanding lets some sort of idea of what might be going on and what you need to work on. Working on discussion and behavioral experiments. Behavioral experiments, including exposure, but not only exposure. Exposure and response prevention is the heart of much of what we do, but there are other behavioral experiments that help you find out what's really happening. You want to make sure that on the agenda is helping you confront your fears. In the end, you can talk and talk, but if you do not put your hand down that lavatory or leave the door open, terrible thoughts that you're afraid of, then you're not going to get it. You're not going to finish the problem off. You need to ask the person to make sure they will support you when they find it difficult. Sometimes that's extraordinary. I mean, the worst case I could recall, 2 years ago, I had a patient. We worked intensively, we worked for 6 hours, and it was absolutely fine until 5 hours, 50 minutes, and we were ready to finish, and the patient then spiked. They had a major issue. I had to work with them for another 6 hours, and I went home at midnight. You have to be able to do that. Okay, they need to help you generalize changes. Okay, so just a couple of things about what you can do to help. You could do some preparation. If you're going for a new therapist, take them a summary of what your problem is and the timeline. Tell them if you find it difficult to discuss things. Say in your thing you write for them, you might say, I find it really difficult to discuss this particular area because it's embarrassing to me. I feel ashamed of it or whatever. And that's helpful. Give them some clues because they can't read your mind. Here's the other thing. Ask them if you can record the sessions. You see, if you talk with a therapist for an hour, you'll remember about 10% of what you talked about. But there's a miracle. The miracle is the mobile phone. And if the therapist is happy with it, you can say, record, and then after the therapy session, you can listen to it afterwards. And what I suggest you do is then you make notes from that, so you remember what the important things you learned in that session were, what the homework was, And things that you weren't clear about so you can ask the therapist later. And that's a great thing to do. Writing things down can help. And the things you write down from recording the session, that's your personal therapy manual. It's things you've learned, and you can check it out. It's good for your therapist to hear what you learned, because then it gives them feedback too. Ask the therapist for reading. Yeah, well, I'd like to find out a bit more about OCD. What would you suggest I read? And then do the reading, and then make notes about that. So I try to make sure, of course, that you're on time and that you participate in sessions. Talked about that already. Yeah. Remember, when you start therapy, you know more about your problem than your therapist does. They might act as if they do, but you're the person who knows most about it. Therapists need your help, but they sometimes don't admit it, so help them with that too. Try to be active and collaborative. Be part of it. Don't just sit there. Join in. Yeah. Ask if the sessions can be audio recorded. During therapy, ask questions, give feedback, and say, whoa, that wasn't so good. Oh, that bothered me. I want to understand that better. It's good. Be clear about your goals. Okay. Beware of seeking reassurance. Reassurance is a trap. Reassurance is checking. And it's turbo-checking. It's supercharged checking, because in reassurance, you don't just check, but you also ask somebody else to check for you and transfer responsibility. Don't be too kind to your therapist. Patients often protect their therapist. Yeah, go in and say, and they've had a rotten week. You had therapy, a rotten week, it's been terrible, you've got worse. And there's a tendency for patients to protect their therapist. Say, well, it's been all right, but, and the therapist here, it's been all right. What they should hear is but. So don't protect the therapist. Tell them the truth. Make sure you're clear about the homework, what you're supposed to be doing. Beware the pessimistic therapist. I'm running out of time. Treat your therapist as a human being. Remember, they have faults and will make mistakes. So forgive them those. Please forgive them those. As long as they acknowledge them. If they pretend they're not making mistakes, sack them. Be prepared to do most of your the work yourself. Therapist is a coach. And there are 168 hours in the week, and that's your life. And that's where you need to take the therapy, not the 1 hour or the 3 hours or the 5 hours in therapy. It's the 168 that matters. Questionnaires can help. It's good. Fill out questionnaires, because that's a way of feeding back to your therapist how you're doing. I'm not talking about that. No. Okay, so I've now finished my bit about getting the notes for therapy.